Okay, thank you. Good morning. So I'm going to talk today about breast cancer when it occurs during pregnancy. I have no disclosures. And I showed the slide yesterday, but about 246,000 new invasive cancers are diagnosed annually, and about 4% of them occur when a woman is pregnant. And so I want to talk about pregnancy-associated breast cancer. And first of all, the definition of that is when pregnancy is diagnosed while the patient is pregnant or within 1 year afterwards. It occurs in about 1 in 3,000 pregnancies, and it's the second most common cancer that's diagnosed during pregnancy, with cervical cancer being the most common. It accounts for about 3% of total breast cancer, and of women with breast cancer who are younger than 40, about 10% will be pregnant, and the average age of someone who is diagnosed during pregnancy is about 33. So in general, the prognosis of breast cancer in young women overall is worse than in women of average age, about 60. And there have been studies to look at the reason for this, and the reason is that young women are more likely to have triple-negative breast cancer or HER2 positive breast cancer. Their cancers are also detected at a larger size because this is an unscreened population, and more likely to be lymph node positive. So as a group, young women have more aggressive cancers, but when you compare pregnant patients who have breast cancer compared to non-pregnant patients, if you match them for stage, the 5-year survival is not different, and that's the same whether you compare node negative, where the 5-year survival is about 82% if they're pregnant versus non-pregnant, and also node positive, where there isn't a statistically significant difference in survival. This is meant to be the effect of breast cancer on the fetus. So breast cancer in and of itself does not affect the fetus. It's very, very rare to have a placental metastasis, and there isn't transmission to the fetus because of immune rejection by trophoblasts. So the effect of breast cancer in pregnancy is really due to the adverse events that are caused from treatment, and I'm going to go through this, which includes anesthetic drugs, radiation, chemotherapy, and hormonal therapy. So the first thing that I want to talk about is what do you do when you have a pregnant woman who has a breast mass? And so my first question to you is true or false? A mammogram should never be done during pregnancy. That's correct. Okay. So the workup of a breast mass is similar to the workup of any mass who comes in a woman. And generally, in women who are young, we start with an ultrasound. Again, mammogram does have reduced sensitivity in young women because the breasts are more likely to be dense. So the first thing that you need to do is an ultrasound. And what you can see in an ultrasound is whether it's a cystic or a solid lesion. And so if you have a cystic lesion, it's a pure simple cyst or a galactocele, you can put a needle into it and you can drain it. If it comes out either milky fluid or a cystic fluid with no blood, you're really done with your diagnosis. But mostly any lesion that is solid or has a solid component needs a biopsy. And the ultrasound has no risk to the fetus. Now, one thing that's really important I want to emphasize, it's extremely important to get your imaging studies before you do any diagnostic procedure. And this is whether you're pregnant or not pregnant. Young woman comes in, they have a mass, you think it's most likely a cyst. Please don't put a needle into it and try to drain it. The reason is that when needles get put into the breast is very vascular. You can get a hematoma or you can get inflammation. And so if a cancer is diagnosed, you may turn what clinically is a 2-centimeter mass. The patient now comes to see the surgeon. There's a hematoma. You get your imaging. The mass looks like it's 4 centimeters. So we would treat that differently because we might consider giving neoadjuvant chemotherapy to shrink it. So always, 100% of the time, please get imaging before putting any needles. The other thing that happens when you put needles into the breast is the lymph nodes become reactive. And so sometimes we'll feel something and it'll be clinically node positive, and that might put us down another pathway. So this is pregnant or non-pregnant. But ultrasound is very, very helpful. Breast MRI has no role in the pregnant patient because with breast MRI you need to give gadolinium, and that is contraindicated in pregnancy. Mammogram can be used. So if you have someone and you do an ultrasound and it looks like a cyst and you drain it, they really don't need a mammogram. But if you have something that looks suspicious, you also want to do a mammogram because that's going to show calcifications or things that you don't see in ultrasound. It's actually safe to do a mammogram with appropriate abdominal shielding. Calcifications are not seen on ultrasound, so if there is something that's suspicious, a mammogram is an important part of the workup. So what about a milk fistula? If I biopsy something, they might get milk draining from the breast. So biopsy of a mass should not be done during pregnancy because the patient may develop a milk fistula. True or false? Right. So obviously anything that's suspicious is more important than getting a milk fistula. Usually milk fistula isn't an issue during pregnancy because the breast isn't really fully lactating. If you're postpartum and you're lactating, you can get a milk fistula. And no one likes to have milk draining from their breast. It's really uncomfortable. You can be more at risk for cellulitis, but the bottom line is you don't want to have a delay in diagnosis of breast cancer, and so if you need to do it, you need to do it. So how do we do biopsies? So the easiest way to do a biopsy is ultrasound guided. So if you can see the mass on an ultrasound, then you do an ultrasound guided biopsy. The patient's lying on their back, and you go ahead and do it that way. If you can see the mass on an image-guided biopsies have better yield than just feeling it and doing it handheld biopsy. If you can't see on an ultrasound, let's say what you see is a density on a mammogram or calcifications, then you'll do a stereotactic biopsy with abdominal shielding. It's not very common during pregnancy because we're not doing routine screening mammograms, so we're not seeing fine calcifications suggestive of DCIS. So the most commonly it's an ultrasound-guided biopsy. And of course, if you have a palpable mass and your imaging's negative, you don't say, yay, everything's fine, because we know that 10% of cancers are occult. And so if there's a mass and the mammogram and the ultrasound are negative, there needs to be a biopsy. Depending on how it feels, you can either do a fine needle aspiration or a core biopsy, or if it's kind of vague, an excisional biopsy. But if there is truly a mass there and the imaging's negative, one way or the other, we need to get a biopsy to avoid a delay in diagnosis. Another common symptom that we see, so sometimes patients are referred for breast masses, other times they're referred for bloody nipple discharge. So here's a question, true or false? Pregnant patients with bloody nipple discharge should undergo a duct excision for biopsy. So in non-pregnant patients, we are concerned about bloody nipple discharge. About 10 to 20% of the time, this will be associated with a breast cancer. And the way we work this up is with a subaerial ultrasound and a mammogram. And if we see a mass, you can do an ultrasound-guided core biopsy. Many times we don't see anything, and in that situation, we do a duct excision in the operating room, and we typically always do this in a non-pregnant patient because of about a 10 to 20% chance of malignancy. However, in pregnant patients, it turns out that this is physiologic. About 20% of women will have blood in their discharge, and so we don't go running to the operating room. This is actually pretty normal. What you want to do if the patient has bloody nipple discharge is you want to do a physical exam. Make sure you don't feel a mass. You want to get a subaerial ultrasound, make sure there's not a mass. You can send cytology and make sure there's no atypia. But we would not go ahead in someone who didn't have a mass or any other findings during pregnancy because this is physiologic. And what we would do is we would do close observation. We would just make sure that after she delivers and stops nursing that it goes away. And then if something persisted, then we would go ahead and do a duct excision. So the decision-making for gestational breast cancer, you have to ask 4 fundamental questions. Number 1, how far along is a pregnancy? How we treat breast cancer is very dependent on what trimester the patient is diagnosed in. We also have to take into consideration what is the size of the tumor and the lymph node status, and then always patient preference. So gestational breast cancer is very important that it has to have a multidisciplinary team approach, including the obstetrician, the surgical oncologist, the medical oncologist, the radiation oncologist, and a genetic counselor. And everyone has to work together with this. So when someone is diagnosed with breast cancer, for early stage breast cancer, we generally don't do staging studies, whether they're pregnant or not pregnant. If they are under 5 centimeters and lymph node negative, we generally don't do staging studies. But if someone has a tumor over 5 centimeters or lymph node positive, then we do staging. And so that would be the first thing. But we can't obviously do our traditional staging studies because you can't do a CT scan during pregnancy. So what we would typically do is we would do a chest X-ray with abdominal shielding, a liver ultrasound, and we would get a CBC, LFTs, and alkaline phosphatase. So that's what we're going to do while they're pregnant. If it's necessary, after they deliver, you could complete that workup. So true or false, 40-year-old woman with breast cancer and no family history of breast cancer meets criteria for genetic testing. Right. So essentially all of these patients are going to, they're young patients, so they need to see a genetic counselor for genetic testing. So the genetic counselors will recommend testing for anyone who's under 50. If a patient has a BRCA mutation, again, the risk of a contralateral new primary is 40% in 10 years. So for the overall treatment, we recommend that they consider bilateral mastectomy, not for the treatment of this cancer, but for the prevention of a subsequent cancer. However, when someone is pregnant, if they have a BRCA1 or 2 mutation, we do not recommend that prophylactic mastectomy occur during pregnancy, because you don't want to have increased anesthesia time. We also do not recommend any reconstruction during pregnancy. It's not, what you want to do is really the minimal amount to take care of the patient, to get rid of the cancer, but you also have to avoid unnecessary anesthesia time. So if surgery is performed during pregnancy, all the prophylactic procedures and reconstruction should be delayed to a future date when they're no longer pregnant. Now, in terms of, should you recommend termination of pregnancy? It is rarely needed to recommend termination of pregnancy. And again, you need to look at what trimester is a patient diagnosed. So surgery and chemotherapy, and I'll go into this in more detail, but they can be administered after the 2nd trimester. Surgical treatment and chemotherapy during first trimester really have to be avoided unless it's necessary for the life of the mother. If it is necessary for the life of the mother, that's a time when there should be discussion about aborting the fetus. And so this actually does happen. You'll read in textbooks that you never need to have termination for pregnancy. I mean, that's not true. If you have someone come in very early, say they're 6 weeks with an inflammatory breast cancer, that's HER2 positive, very aggressive, you can't wait 8 weeks to start chemotherapy for that, okay? And you also can't give Herceptin and pertuzumab during pregnancy. So in some, and this actually, we had a patient recently, it was very unfortunate, but that had an inflammatory cancer, had surgery, had a rapid recurrence, and she was before 14 weeks, and so we did recommend termination. So in medicine, there's always exceptions, right? And the exception for pregnancy is really a very early first trimester, very, very life-threatening aggressive cancer. But most of the time, it's not necessary to terminate a pregnancy. When I was looking at this, there was a study that locally advanced breast cancer in young women, there was a study that showed a reduced survival if therapy was delayed over 6 weeks. And so that's really something that we want to look at. So if you have someone who comes in with a 2 centimeter ER positive, clinically lymph node negative breast cancer, and they're at 7 or 8 weeks, it's really not going to be detrimental to wait 4 weeks until the patient's at 12 weeks to do surgery. But you have to look, again, how aggressive is this cancer? What kind of time do you have to wait? And this really only is an issue in the first trimester. In terms of anesthetic issues, so if a patient's going to have surgery during pregnancy, most of the time we need to do general anesthesia. It's difficult to do most of these operations under local. So the anesthetic agents are not teratogenic. The paralytics that are used do not cross the placenta. Inhalation and local anesthetics, narcotics, and benzodiazepines are safe. The overall miscarriage rate is about 6%, and so that's what we counsel our patients about. If it is in the first trimester, it's about 10%. And the anesthesiologists are aware of maternal physiologic changes due to anesthesia. The uterus pushing on the diaphragm decreases the functional residual capacity by 20%, so they have to avoid hyperventilation and respiratory alkalosis. And these are things that the anesthesiologists need to monitor for. In terms of surgery during pregnancy, if it is safe for the mother for her life, then the surgical procedure should be avoided during the first trimester. And most of the time it's safe for the mother. Surgical procedures in the third trimester have a risk of preterm labor, and so this is something that we work very closely with the obstetricians to discuss when the patient should be induced. Usually it's about 37 weeks, and so if you want to do surgery in the third trimester, usually wait until the patient gets induced and then do surgery in the postpartum period. Again, has a lot of multidisciplinary coordination. Now, in terms of breast preservation, in terms of surgical options, there's always the option of either breast preservation or mastectomy. And just to review, in normal situations, there's no difference in survival between breast conservation versus mastectomy. There were 7 prospective randomized studies that proved that. In general, women under the age of 40, this is not patients who have a genetic predisposition to breast cancer, but in patients under the age of 40, the local recurrence is higher with breast conservation than the average woman. So we typically quote about a 10% chance of a local recurrence with breast conservation. For women who are under 40, it's about 20%, but there's still no difference in survival for a young woman, whether they have breast conservation or mastectomy. But we do counsel them that they are at a higher risk of local recurrence, and many people are fine with that. They still want to go ahead and preserve the breast. In terms of preserving the breast when someone is pregnant, it comes down to timing. So when somebody has a lumpectomy, we need to give radiation afterwards. And the reason for that is that the local recurrence, if we just did a lumpectomy, is about 40%. Radiation reduces that to 10%. And the bottom line is that, as you know, radiation can never be administered during pregnancy as an elective procedure. So there's really critical timing decisions. Breast conservation is only an option if radiation is delivered after the patient has delivered the baby. And that just comes down to timing. And so things that we look at is, if you are in the third trimester when you're doing the lumpectomy, it's okay, to give radiation afterwards. Some patients may have early second trimester, have a lumpectomy. If we know they're going to get chemotherapy, the chemotherapy is administered during the pregnancy, and the radiation can then be done after the patient's induced. But if it falls that you do a lumpectomy in the early second trimester and the patient doesn't need chemotherapy, it's really not acceptable to do a 6 months delay in radiation. So it all comes down to timing and multidisciplinary care, and the bottom line is you can't give radiation during pregnancy. And then, of course, you do need to consider genetic testing and the consequences of that. And just to reiterate, if a mastectomy is done during pregnancy, immediate reconstruction is contraindicated because of the risk to the fetus with the prolonged anesthesia time, and we do not do prophylactic contralateral mastectomy during pregnancy. That can be done at a later date. In terms of axillary procedures during pregnancy, so we always want to know, has the tumor spread to the lymph node? And we want to know this because it goes into our stage. It helps guide our adjuvant therapy, including chemotherapy and radiation therapy. So the workup of a patient is not only a physical exam, but a high-resolution axillary ultrasound. And if something is suspicious on ultrasound, we'll go ahead and do a core biopsy of the lymph node. If that comes back positive, then the patient is clinically node positive, and we would generally do an axillary lymph node dissection. If the physical exam is negative and the ultrasound's negative, then in general, in a non-pregnant patient, we would do a procedure called a sentinel lymph node biopsy. And what that is, we inject technetium sulfur colloid and a blue dye into the breast, and that dye travels to the axilla and will remove the sentinel nodes, which are usually about 3 lymph nodes. And if those lymph nodes do not have cancer, we can avoid doing a lymph node dissection. Now, when the sentinel node procedure was being developed, it was developed 2 ways. Some people use technetium sulfur colloid only. And with that procedure, you could find the lymph node about 93% of the time. Some people use blue dye only, and with that procedure, you could find the lymph node about 87% of the time. But when they combined the technetium and the blue dye, we could find the lymph node 99% of the time. So in a non-pregnant patient, the standard for doing a sentinel lymph node biopsy is to use both the technetium and the blue dye. So in pregnant patients, it turns out that the blue dye is contraindicated. It's not. I don't know if it's known to be a teratogen, but it hasn't been studied, and so you really can't use blue dye in a pregnant patient. It turns out that technetium actually is safe during pregnancy, as long as it's not in the first trimester, and so you can do a sentinel lymph node biopsy with technetium only. You might not map. If you don't find a sentinel lymph node, then you need to do a lymph node dissection. So that's the way we would go ahead and deal with that. The indications for chemotherapy in a pregnant patient are the same as for someone who's not pregnant. And so the things that the medical oncologists look at are the tumor size, the lymph node status, and estrogen, progesterone, and HER2/neu. So basically, if someone is lymph node positive, they're going to get chemotherapy. If they're lymph node negative, many patients still get chemotherapy. So if someone has a tumor over 1 centimeter and they're triple negative, even though it's a small cancer, the triple negatives are more aggressive and they're going to need chemotherapy. And likewise, HER2/neu positive breast cancer is very aggressive. And so if it's over 5 millimeters, they're going to need chemotherapy. And in the ER positive patients, nowadays we do a test called an oncotype, which looks at gene expression in the tumor and can help differentiate if that ER positive tumor is aggressive or not and whether or not chemotherapy is warranted. So the same indications for chemotherapy are considered in pregnant versus non-pregnant women. So most drugs with a molecular weight under 600 kilodaltons are capable of crossing the placenta, and most chemotherapy agents have a molecular weight of 200 to 400 kilodaltons, so they do cross the placenta. There's other things that we have to think about during chemotherapy during pregnancy, is that there are PK changes during pregnancy. There's an increased plasma volume, increased renal clearance of drug, faster hepatic oxidation, and third spacing in the amniotic fluid. Most cases of toxic effects reported are when treatment has been given during embryogenesis in the first trimester. And so chemotherapy is contraindicated before in the first trimester, and actually not until about 14 weeks. Many chemotherapeutic agents can be administered safely during the 4th to 9th month. Hormonal therapy is contraindicated, and Herceptin is contraindicated as well. And if someone is postpartum and they're receiving chemotherapy, breastfeeding is not recommended during chemotherapy, hormonal therapy, or Herceptin because of transmission. So the side effects of chemotherapy by gestational stage, in the first trimester there's about a 20 to 30% chance of abortion and about a 10 to 25% chance of malformation. In the second and third trimesters, you can have intrauterine growth retardation, low birth weight, miscarriage, and premature birth about 20 to 40% of the time. And in the perinatal period, you can have maternal fetal myelosuppression, infections, and hemorrhage. So those are, things that need to be discussed with patients. In terms of late effects, there have been studies that have showed no detrimental effects on physical and neurocognitive function, gonads or second tumors in the children that have been treated in utero with chemotherapy. So anthracyclines is a type of chemotherapy that's most commonly recommended in breast cancer. It also has been most studied in breast cancer and is a first choice. So something like adriamycin. Cyclophosphamide is a common drug that's used in breast cancer. It's safe. The major malformations are about 3%. And paclitaxel, there's no data on placental transfer. It is used in breast cancer if it is indicated based on the patient's tumor type. So most commonly it would be adriamycin cytoxan with or without paclitaxel. In terms of does pregnancy affect the prognosis of breast cancer, again, stage for stage, there isn't a difference in survival stage for stage. However, there is a known delay in diagnosis. When a woman is pregnant, the average delay in diagnosis is about 1 to 2 months, although in individual patients it can be longer. Sometimes it might be thought that it's just a cyst or a galactocele, or there might be hesitance to do imaging during pregnancy or really to do a regular workup. A 6-month delay in diagnosis increases the risk of lymph node involvement by 10%. So again, it is very important to work up all breast masses in a pregnant patient. But stage for stage, again, there's no difference in 5-year survival between pregnant and non-pregnant patients. But again, the problem is that breast cancer in any young woman happens to be more aggressive because they have more aggressive disease.